Hi everyone. Now it's 3:30, so we're gonna start the next session. Okay. We are the co-moderators of this session. My name is Hideki Ota from Tohoku University.
Okay, hello everyone. My name is Binbin Sui from Beijing Tiannan Hospital.
Thank you. Okay, so the first speaker of this session is Dr. Chen Zhu. So his title is Intracranial Neurosome Wall Enhancement and Morphological Features Predict Neurosome Growth and Rupture. Oh, sorry, before that, this is the second one, right? Yeah, so could you just change to the previous one? Okay, so first talk is intracranial neurosome wall enhancement and morphological features predict the neurosome growth and rupture. No. This. Okay, so actually he has two talks. So this is the first talk. Intracranial neurosome wall enhancement and morphological features can classify or remodeling type in vivo.
Hello. Okay. Yeah, thanks for the introduction. Sorry for the inconvenience. So today I will give two talks on intracranial aneurysm enhancement, back to back. And the first talk we will talk about the histology validation. And this is a collaboration project between Beijing Tiantan Hospital and the University of Washington. So aneurysm is a very common disease and is a major cause of subcoronoid hemorrhage. And rupture IAs are fatal in about 50 of cases. And of those who survive, about 2/3 suffer some permanent neurological defect. And the rupture risk of unruptured aneurysm increases with size. And normally 7 millimeter is a cutoff to balance the rupture risk and surgery risk. However, a large amount of small aneurysms less than 7 millimeter also rupture. So it is important to find new imaging markers to identify UIA stability. to select these high-risk small aneurysms for early intervention to prevent their rupture. And the aneurysm wall enhancement is actually a very promising biomarker, and it can be seen on the gadolinium contrast-enhanced vessel wall MRI. As we can see here, the pre and post contrast, we can see the aneurysm wall enhanced. And it's not still clear why there is an enhancement here. And the gadolinium can go to the wall through this vessel viscerum in the adventitia, and also possibly it can penetrating to the wall directly from the lumen. And there are several small sample studies using the clip surgery specimen and found it is associated with macrophages and neural vessels. However, there are several limitations of the previous study. It's a very small sample size, only a qualitative description of histology features, and there is no quantification of the wall enhancement. So the aims of our study to identify whether quantitative wall enhancement ratio and morphological features can differentiate histological types or wall remodeling in a large cohort. And we include 237 UIA patients who have macrosurgical clipping, and between 2017 and 2022 at Tiantan Hospital in Beijing. And all include patients who receive pre and post contrast enhanced vessel wall MRI on Siemens 3T scanner using a space sequence, which is a 3D turbospin echo sequence with variable flip angle train, 0.6 millimeter isotropic resolution and 7 minutes scan time. The main inclusion criteria is more than 5 millimeter in size and unruptured IAs. And we collect patient clinical information and also morphological features, including maximum diameter, aspect ratio, size ratio, irregular shape, and also aneurysm location. And aneurysm specimen were collected during the surgery, and the sac of each IA distal to the clip was resected and intraluminal thrombus was removed. We use HE staining to identify histological types. And here shows how we do the qualitative and quantitative measurement of wall enhancement. On the left, we can see this is pre and post contrast, and this aneurysm have no enhancement, and this aneurysm have a circumferential enhancement, and this aneurysm has a focal enhancement. And for the quantitative, we use a wall enhancement index measurement using previous published criteria. And for the histology types of the wall remodeling, it's also adopted from a previous classic histology paper. And we divided into about three types. Type A is a low risk, is the endothelium cells are well organized. And type B and C is medium risk. You can see the thickened and hypercellular wall with disorganized cells. And type D is a high risk, is extremely thin thrombus lined hypercellular wall. And for these patients, we divided into development cohort and also validation cohort. We actually use two methods to analyze the data. The first one is a multivariable linear regression model, which is very easy to use. We try to differentiate low risk and medium to high risk types. And then we perform a little bit more complicated machine learning method, which is not widely available, but it can differentiate three types at the same time. And we use lasso to select the important features. And we do the ROC curve and quantify the area under curve value. We do several comparisons of the Fano model of linear regression and also machine learning. And we also try the model without wall enhancement features. And we also compare with clinical models of faces and elapse. And here we can see the different features of the three histology types. We can see on the left, for the clinical parameters, they are very similar among the three types. And we also notice the MC aneurysm is the majority of the aneurysm. That's because these aneurysms are more feasible for the open surgery. But for other aneurysms, maybe the endovascular treatment is more preferred. And on the right, we can see there is a significant difference, for example, for the high-risk type D aneurysm. It is much larger in size, larger in aspect ratio, size ratio, and also more irregular shape, and also much higher enhancement ratio compared to the low-risk histology types. And we also see the face and elapse score are higher. And then we use lasso to select these four important features: aspect ratio, size ratio, wall enhancement index, and irregular shape. Then we build a nomogram model which gives each feature a score, and then we choose the best cutoff is a 90 score. If it is higher than this, it's a high risk histology type, and it's lower, it's low histology type. And overall, this nomogram model achieved about 85% area under curve value. And if we remove the wall enhancement, it reduced to 77, and it's much higher than the faces or ELAPSE score, which is around 60. And for the machine learning model, we can see achieve the AUC of 0.92 for the 3 histology types, both in development and validation cohort. It's better than the machine learning model without wall enhancement and also the traditional risk scores. So overall, we found these wall enhancement features play a critical role in classifying histology types. And here there are 2 cases. So for this aneurysm, we can see the post-contrast, there is no enhancement. We got these parameters, and we guess, the classifier guess it is a type A low risk. And when we do the surgery and get the specimen out, it is correct, it's a low risk. And for this case, we can see there is a strong enhancement. Also, this classifier identifies most likely a type D. And when we do the surgery and get the specimen, it's correct, it's a type D. So overall, based on this large cohort of aneurysm specimen, we found size ratio, aspect ratio, and irregular shape and wall enhancement index were identified as features of aneurysm wall remodeling. And the machine learning classifier, including wall enhancement and morphological features, performed very well, better than the model without wall enhancement and traditional scores. So in conclusion, wall enhancement and morphological features can classify histology types of intracranial aneurysm in vivo. And the vessel wall imaging may be useful for risk stratification of UIA patients. Thank you for your attention.
Thank you, Dr. Zhu. So now this talk is open for discussion. Charles?
There should be a switch there.
Okay, sorry. I'm a little confused. I thought the high-risk aneurysms had the thin acellular wall, so why would they enhance more than something that's got a thick cellular wall? That doesn't make sense to me. Or did I pick that up wrong?
Yeah, so the high-risk wall is a very thin wall, but it's often have a thin, linear of thrombus, intraluminal thrombus as well. And also, actually the medium risk one is a thickened wall, right? But the enhancement not only depending on the thickness of the wall. If the wall is like kind of fibrillized tissue, it's not really enhancing. But if the wall is thin, but it's kind of, there is a vessel of or like neurovessels from the adventitia, the contrast agent can come in. Yeah.
I'm still confused. Okay.
Okay. So any question? Okay. So thank you for your talk, and we will move on to the next his next talk.
Can I still use my?
Yeah. Okay. So next talk is about the large-scale multi-center longitudinal study about the intracranial aneurysm wall enhancement. Please.
Okay. Thanks for the introduction. So I will continue on this topic. So last talk is about understanding what is wall enhancement by histology. This time we will test it really in a clinical setting, whether it can predict aneurysm growth or rupture. I will skip the introduction. So the key question is, can wall enhancement predict aneurysm growth or rupture? So there are some cross-sectional studies found enhancement was independently associated with symptom, but there are very few longitudinal studies. The largest one from Marie Magilali in France showed wall enhancement increase during follow-up predict aneurysm growth, but from this nearly 130 patients, only 12 patients has growth during this 2-year follow-up. That's because it's by nature the aneurysm has a very low annual growth rate or rupture rate. So the still gap in the knowledge. The previous study had a small sample size, very few outcome, only single center studies and no rupture as an outcome and no quantitative wall enhancement analysis. So the aims of our study is to test whether wall enhancement and morphological features can predict growth or rupture in a large-scale multi-center longitudinal study. So we involve single UIA patients from 2 prospective multi-center studies. The first one is the IARP study used as a deviation cohort, and the second one is the 100 project cohort used as an external validation cohort. The inclusion criteria is unruptured aneurysm more than 3 millimeter. Some patients have more than 7. We are still include them if the patient prefer not to treat. And all of the aneurysm are asymptomatic. And part of the patient in the clinical trials was scanned vessel wall MRI, a similar protocol in my previous talk, and follow up with CTA every half a year for 2 years. And the same, the primary endpoint was aneurysm rupture or growth defined as more than 1 millimeter increase in size, or morphology change becoming irregular shape. And we used a Cox regression model in a deviation cohort, and then it was tested using a validation cohort. We also compared the AOC values. So in total, 709 patients were included, 559 in the deviation cohort, and 146 in the external validation. So in the deviation cohort is of the 985 patients in the clinical trial, we were able to include 57% to have a vessel wall MRI. And there is no significant difference in patient demographic data between included patient and excluded patient without MRI. So there is no significant selection bias here. And during the 2 years follow-up, about 11% patients have events, about 16 rupture and 45 growth. And in the validation cohort, about 146 patients, there are actually a higher event rate, about 19%. It's 4 rupture and 24 growth. So this higher event rate in the actually external validation cohort, possibly because that cohort has a larger aneurysm size on average. It's about 6 compared to the 4 millimeter in the deviation cohort. And here we shows in the development cohort, the compare was stable aneurysm and unstable means they have events. So you can see also the clinical information are very similar, but we can see the aspect ratio, size ratio in regular shape is higher or more frequent in the unstable aneurysm, and the size is much larger. And also there is a much higher wall enhancement in this cohort. But the phase and elapse doesn't work quite well, possibly because in this cohort aneurysm are on average quite small. And similarly, we use lasso to select these features. There are 4 features: aspect ratio, size ratio, wall enhancement, and irregular shape. You can see it's really a coincidence. It's similar as the histology high-risk types. So it really means several features are really important. And we also build a similar nomogram model, and we achieve an overall accuracy of 90%, which is considered high. And here is a case. For example, the baseline, we see some focal enhancement, and we get these values. And using the nomogram model, we got the total points, and we classify as a high risk. And during follow-up on CTA, we can see there is a significant growth here. And we compare the model with all the features, and also we remove vessel wall imaging feature. We found it's dropped from 88% to 72%, which is very significant, and the clinical score really doesn't work. So similarly, we found this wall enhancement is very important, critical role in predicting aneurysm growth or rupture. And this is the final Cox survival plot in the validation cohort, and we found a similar trend, but we also see the phase and elapse actually perform better in this cohort, but still lower than the wall enhancement, possibly because this aneurysm size is bigger at a larger range. And here's these 3 cases, and this aneurysm has a strong enhancement here, and is during follow-up it ruptured. And this aneurysm also has a strong aneurysm enhancement here, and during follow-up it grows. And this aneurysm, we see there is no enhancement, and during follow-up it is very stable. So in conclusion, we found wall enhancement and morphological features can predict aneurysm growth and rupture, which may help guide treatment decision making. And our sample size is more than 5 times larger than the previous largest study, providing the strongest evidence so far in this field. And the use of quantitative wall enhancement characters may help the model to achieve a very high accuracy, which was much better than the traditional risk scores and provide additional value in the outcome prediction. And the utility of our model need to be validated in other international cohorts. We are currently the only Chinese data. And also we can test it in the future randomized controlled clinical trials. Yeah, thank you for your attention.
Thank you for your excellent study. So now this talk is open for question and discussion. So question for me. So I'm just want to make sure that in your follow-up study you used both MR and CTA, or just MRA to measure the size.
Yeah, we only use CTA to measure. Well, at baseline, I maybe didn't mention, at baseline the aneurysm also have a CTA or DSA. Yeah.
Oh, okay. I know you have so many cases, and how the reviewers are defined. I mean, so many cases. Did you review by yourself or your colleagues? Or because this is a kind of the subjective visual assessment in terms of the wall enhancement.
Yeah, this is a multi-center study, but there is a central analysis core at Tiantan Hospital. So actually, all the measurement I believe is by the neurosurgeons rather than the radiologists. So it's a central analysis core. Yeah.
Okay. Thank you. So, yes, please. Please give him microphone.
I have a kind of a technical question. Very nice study, Chen. So for aneurysms, there could be some stagnant flow or slow flow. Oftentimes, especially if you're looking at wall enhancement, which could be maybe susceptible to those residual blood signal.
Yeah.
Is that, did you play some tricks in the sequence, or do you think the current techniques are already sufficient?
Yeah, I think there is definitely a lot of flow artifacts here, but you know, we have the flow suppression Dante space sequence, but this is a multi-center study involved like 20 centers. So they all have Siemens scanner, but it's very hard to really install a research sequence at each center. So I think that's a kind of challenge here. We do a really big clinical study. It's very hard to use this research sequence, but in the future we will try to use blood suppression techniques.
Okay, thank you. And yes.
Nice presentation. I have a question about your study. Is a multi-center study, and how about the results of different MR scanner?
Oh, we all have Siemens 3T scanners.
Oh, sorry.
Thank you. So we will move on to the next presentation. So next presenter is Dr. Yannis Kotzrow. The title is Improved Conspicuity of Cerebral Arteries Using Distal Subtraction, Quantitative Time-of-Flight Magnetic Resonance Angiography.
Thanks very much, Dr. Oda, for the introduction. It's a pleasure to be here and be able to share with you kind of an approach to improve arterial conspicuity in the brain using a quantitative variant of time of flight that provides both structural as well as hemodynamic evaluation of cerebral vessels. These are my disclosures. I think as we know, measurement of intracranial hemodynamics can be helpful for evaluating an array of neurovascular disorders, including stroke and vascular dementia, but also for tracking disease evolution and progression over time. And we heard earlier today that time of flight, MR angiography is the standard MRI approach that's routinely used in clinical practice for evaluating the intracranial arteries, but unfortunately does not provide quantitative hemodynamic information, which potentially represents a missed opportunity. Quantitative time of flight is an emerging approach for head MR angiography that provides simultaneous morphologic and hemodynamic evaluation of the intracranial arteries with similar overall image appearance, scan times, and spatial resolution with standard time of flight head MR angiography. However, the arterial to background contrast of the quantitative time of flight method has not yet been optimized, and improved arterial conspicuity would be desirable. So the purpose of this study was to evaluate, whether a digital subtraction, signal subtraction strategy could be applied to quantitative time of flight to improve the conspicuity of the cerebral arteries without lengthening the total scan time. And this was an IRB approved study, and written informed consent was obtained from all the participants. Imaging was done on a 3 Tesla magnet. We included 20 patients with a history of cerebrovascular disease, including patients with intracranial arterial stenosis, intracranial aneurysm, vertebral artery dissection, as well as extracranial internal carotid artery stenosis. And the quantitative time of flight technique was acquired with a voxel size of approximately 1/3 of a cubic millimeter, which matches the spatial resolution of standard time of flight head MRA we obtain clinically, and scan time was 4 minutes. So just a brief overview of the quantitative time of flight head MRA pulse sequence. It's very similar to standard time of flight head MRA, where luminal evaluation is obtained from the first echo time of a thin overlapping slab, 3 spoiled gradient echo readout. We do acquire multiple echoes, in particular 3 echo time readout is used, where we can quantify arterial flow velocity from small displacements of arterial signal across acquired echo times here, and simple velocity is just distance over time, and this is done using a computer vision-based algorithm. With regards to the digital subtraction variant, which is kind of the focus of today's talk, it's very similar, but we acquire an additional 4th echo time that is preceded by flow dephasing gradients. What these flow dephasing gradients do is they suppress arterial blood signal on this 4th echo time through flow-related dephasing, and then we subtract away this 4th echo time from the angiographic 1st echo time to suppress background tissue signal and hopefully improve arterial to background contrast. Importantly, this can be done without lengthening the total acquisition time, because the sequence repetition time is unchanged. We looked at a couple image analyses. We mainly wanted to look at arterial background contrast, contrast to noise ratio, as indicated by these 2 equations. And what we did is we generated maximum intensity projection images with and without signal subtraction. And these were randomized and evaluated by 3 experienced readers, 1 radiologist and 2 stroke neurologists. So this is just an example of a patient with a left P1 stenosis with a stroke history. This is kind of the quantitative time flight MIP image here. We can see the stenosis, but with the digital subtraction variant, we can see kind of this improved arterial background contrast. Still see the stenosis, but when we look closely, we see improved small vessel detail with this digital subtraction strategy. This is just another example, a patient with multiple arterial stenoses with stroke history. Again, we see the pathology well on both acquisitions. However, for smaller vessel detail, we do get some improvement with this digital subtraction approach. When we looked at arterial to background contrast, we found that the digital subtraction approach provided 5.3-fold larger contrast, as well as 9% larger contrast to noise ratio and both of these differences were statistically significant. When we looked at reviewer preference, so we had 3 readers, we found that this digital subtraction quantitative time of flight was consistently preferred over kind of standard quantitative time of flight in all 20 cases by all 3 reviewers. And although not the focus of this study, it's important to note that we also obtained quantitative hemodynamic data with this digital subtraction quantitative time of flight technique. And this slide shows a montage of mean cross-sectional flow velocity maps on an arterial segmental basis in all the patients that were included in this study. So kind of wrapping up, we found that a subtraction of an additionally acquired dark blood echo provided quantitative time flight head MRA images that were consistently preferred by readers, as well as significantly improved arterial background contrast and CNR without lengthening overall scan time. And future studies will hopefully evaluate whether this approach, how it may impact disease detection and evaluation, but also its impact on hemodynamic measures, especially in the longitudinal evaluation of patients. So with that, I'd like to thank you very much for your attention. I'd like to thank my colleagues within the North Shore University Health System Center for Advanced Imaging, and last but not least, the patients who kindly participated in this research study. Thank you.
Thank you for the excellent talk, and now it's open for discussion. Okay, so I have one question. So you showed us the depiction of small arteries, patent arteries will be improved, but is there any way for the stenosis measurement that may be influenced or affected by your new technique as compared with the conventional one?
Yeah, that's a good question. We haven't looked at like a quantitative evaluation of stenosis, but that's something we need to look at closely. I think it's, we also have to look at what happens to the hemodynamic measures. So that's something we hope to look at in the future.
Ah, okay, yeah. Just like static time of flight image looks clear and beautiful, so that I'm just curious about that. Okay.
Oh, okay, thanks. Yeah, we still have to look at that. But great question. Thank you.
Thank you.
Sorry, I have one question. I see that you have got hemodynamic data, velocity data of the intracranial arteries by this Q-TOF MRA. Have you ever tried to compare this with ultrasound Doppler or photo flow imaging, or use other ways to validate this velocity?
Right, so this is an ongoing study, so we're still accruing patients. We are comparing with 3D phase contrast because it's roughly around the same time, scan time. Right, so we're working on that. I mean, so far the results have been very good. We get excellent agreement in terms of component flow velocity and good agreement in terms of total flow velocity, but we're still accruing patients right now, and hopefully we'll be able to present that possibly next year at this meeting. But yeah, great point. But yeah, we are comparing with regular phase contrast that we all know and love. But the key thing about this approach is that it may not require additional imaging, right? It would provide structural information at the resolution we get now, but also give us the flow information for free. So that's kind of the spin here.
Yeah, thank you very much.
Thank you.
Okay, so let's move on to the next talk. So the next speaker is Dr. Thorsten Bray. His talk is MR BUS score, standardized MR scoring system for assessing the extent of inflammatory burden in giant cell arteritis.
Thank you very much. Good afternoon, ladies and gentlemen. These are my disclosures. And as you all may be aware, systemic vasculitides are separated according to the vessel size that is affected. Small vessel, medium vessel and large vessel vasculitities, and we will focus on large vessel vasculitities and specifically on giant cell arteritis in these 7 to 8 minutes. Giant cell arteritis has a predominance of elderly females, 3 to 1 as compared to male, and it typically occurs at the age of 50 plus years with new onset of headaches, which on palpation is as a superficial temporal artery is hardened and painful, and the ESR is elevated in those patients, and the histology is the ground truth, if you will, which shows granulomatous panarteritis, as you can see on those images. Now, within the last years, imaging has become more and more important in assessing vasculitities, and color-coded duplex sonography is the imaging modality of first choice. And what you will see is this halo around the artery, which resembles the thickened arterial wall, and you can see it on longitudinal and cross-sectional images nicely. Now, this is observer-dependent, and you need specific training. With MR imaging, you can use very high-resolution MR imaging, as depicted in the sequence that we use, and that allows you to enlarge to the area of interest, which is, in this case, the superficial temporal artery without any blurring or artifacts because of the high resolution of roughly 200 by 260 micrometers by 3 millimeters. So it's a spaghetti voxel, if you will. And comparing the affected segments to non-affected segments, this slide shows on the upper row 2 non-affected artery segments, and you can see in the arterial wall there is some vasovasorum enhancement here marked or here, as compared to the vivid enhancement that is affecting the thickened vessel wall plus the extraarterial soft tissue. And also, please note the vein, the concomitant vein, has no flow void as compared to the artery with a higher flow. There's this black blood lumen. Now, since this is a systemic disease, it makes sense to assess more than just one specific area that may be affected. And our proposal is to use a high-resolution MR scan of the skull arteries, an MRA, first-pass MRA of the thoracic aorta and the supraaortic arteries, and then a MRI of the aortic wall, and have this combined protocol in less than 30-minute acquisition time to have an assessment of the disease. And then you will see stenoses, occlusions, as in this case in the right vertebral artery, and you can also see the thickened vessel wall of the right vertebral artery here. Now, the purpose of this study was to establish a vascular activity score to follow patients over time to get a grip on the disease activity in those patients, because that is the key question to rheumatologists nowadays, to us radiologists: how active is disease? In the past years, we were, as a society, actively developing studies and techniques to assess activity at a certain point, but in rheumatology, they want to know and adjust their therapy according to the activity. So we conducted a prospective study with 80 patients, all comers suspected of giant cell arteritis. It turned out to be 50-50, 50% of which were giant cell arteritis positive, and applied this 20-vessel vascular score that includes the superficial cranial arteries, 3 on each side, the aorta with different segments, and the supraaortic arteries. And each segment was evaluated, yes, active or no, non-active in disease. And 4 blinded readers reviewed the images, 2 experienced board-certified radiologists and 2 third-year residents. There was inter-rater agreement score with the Cohen's kappa and the intra-class correlation coefficient for the score. Now, these are typical findings of the scalp arteries, and the arrows mark, for example, the occipital arteries, which are heavily inflamed bilaterally in this particular patient, but also the main stem of the temporal artery on both sides. And on this image, you can see the the frontal branch of the left temporal artery, which clearly shows signs of inflammation. We're looking for the donut-shaped appearance, the circumferential thickening of the vessel wall, as you can see by this little enlargement, or if it's a longitudinal aspect of the vessel, the Tremprek sign, if you will. So inflamed artery lumen and inflamed artery wall again, so it looks like a Tremprek. And in the aorta, it's sometimes difficult to discern regular vasovasorum enhancement of the aortic wall with inflammatory enhancement or remodeling processes. And we use a 2.2 millimeter cutoff for thickness of the aortic wall, which came from a French study with over 500 patients deciding whether there is aortitis or not. This is in the thoracic aorta, but also in the upper abdominal aorta, what was used. And the images were read by those 4 readers, and the vasculitis patients, 40 of which were positive, showed in 36 cases at least one investigated vessel active, and in the controls, 38 of the controls, of the 40 controls, were totally non-positive or negative for these questions, with a sensitivity and specificity of 90 and 95%. And inter-rater agreement and interclass correlations of good and even excellent for the intraclass correlation. So we conclude that this proposed MR-Vascular score could be a tool for standardized assessment of activity, and interesting will be how the follow-up over time, when we have this cohort over a few years, will develop, how this score will help to discern active disease from inactive disease. Thank you for your attention.
Thank you. Charles?
Hi, Torsten, that's lovely. We've talked a lot about this, but in terms of inter-rater agreement, these are all quite elderly patients. You must come across atherosclerosis, which can also enhance. How do you tell whether you're looking at atherosclerosis versus inflammatory giant cell arteritis?
Judge, that is a very good question. And we certainly look for the centricity of the lesion. So to call it vasculitis, it must be circumferential, homogeneously enhancing. And in my power pitch presentation later on, I will show for the intracranial vessels how atherosclerosis differs from vasculitis in this high-resolution imaging. So in atherosclerosis, it's always, in my experience, starting at some culprit lesion, eccentric, and then eventually may grow and grow and grow and become circumferential at some stage, but then you have a large bulk of disease in one direction, as compared to vasculitis, which has always been circumferential, homogeneous, and it's morphology, basically.
Yeah, thank you.
Any other question? I have one quick question. Sorry. So we, according to the guideline from Europe, I think it's 2018, recently updated one. So they mentioned that we will use black blood imaging for large vessels as well. So, but it seems you didn't scan the black blood imaging for large vessels. So how do you think about it? Because I'm always struggling with the scan time for the black blood imaging for large vessels. So.
Well, I think you're totally right. This EULAR imaging recommendation, I was part of the committee, so I was actually voting for MR and fighting for MR's role in this statement. We do look at black blood imaging. If you look at the scalp arteries, they are all black blood, and also for the, it's a VIBE sequence. That's different for the aorta, that's right. I wish I could have time enough to have black blood imaging of the aorta plus vessel wall imaging of the aorta. But yes, this is not included in our protocol yet.
Okay,
yes.
Thank you. Okay. So let's move on to the next talk. Okay, so next speaker is Dr. Renaud Ribera, and title is Cerebral Perfusion and CSF Velocities in preclinical Alzheimer's?
Thank you for the introduction, and hi everybody. Healthy brain function relies on the coupling of various neurofluids, including arterial and venous blood flow, and also CSF flow circulation. It aids with oxygen delivery and metabolic waste clearance. The most common cause of dementia, as you know, is Alzheimer's disease, which is characterized by this Alzheimer's pathology, which is a problem with production and removal of particularly amyloid and tau proteinopathy. And we think that perhaps it's an impaired waste clearance problem. I imagine that some of you have heard of these models called glymphatics, and there are other proposed models, but almost all of them hypothesize that CSF circulation along the perivascular spaces help remove metabolites from the brain and clear the brain from these amyloid, for example. Importantly, most of all these models assume that cardiac pulsatility or cardiac-driven motions, forces are driving this CSF clearance. So another interesting fact is that impaired vasculature is highly prevalent in Alzheimer's disease, with cerebrovascular disease being found in more than 60% of Alzheimer's disease patients upon autopsy. And in our previous studies, we have observed multiple vascular-related findings in populations with Alzheimer's disease, including we have seen lower blood flow rates, stiffer vessels, and reduced flow oscillations on Alzheimer's patients. But we have never had the opportunity to study how CSF flow motion relate to these vascular changes in Alzheimer's disease. So our study objectives were to study neurofluid dynamics during aging and during preclinical Alzheimer's disease. And to do this, we use, to measure arterial and venous blood flow, we use high-velocity encoded 4D flow. To assess perfusion, we use multi-delay arterial spin labeling, and to assess CSF flow, we use low-velocity encoded 4D flow, where we assess CSF through major cerebrospinal fluid conduits, but in theory, we have access to many regions of interest in the whole brain. And just to highlight, most of 2D phase contrast studies are done that study CSF flow motion. They perform their measures at the level of the cerebral aqueduct or spinal canal. And actually, the data that I'm going to be showing today is all on the cerebral aqueduct, but we look forward to the future to add other regions of interest. And some details about the MR protocol that we use. We did our structural imaging to segment different tissue classes and CSF spaces, multi-delayed arterial spin labeling to help with delay filling in these elderly populations. And our flow imaging, we did 80 centimeters per second for blood flow imaging and 5 centimeters per second for CSF flow imaging. And all Alzheimer's disease biomarkers were obtained from PET imaging, where we use carbon-11 PIP to determine amyloid burden, and fluorine-18 MK6240 to determine tau burden. And then we use some population-based thresholds to establish who were positive or negative. We did perform a standard 4D flow processing. In blood flow imaging, data were retrospectively gated to 20 cardiac phases. CSF flow data was acquired with using prospective gating, but then interpolated to 20 cardiac phases. And our participant demographics were recruited from the Wisconsin Alzheimer's Disease Research Center and the Wisconsin Registry for Alzheimer's Prevention. These are risk-enriched populations for late onset Alzheimer's disease. We had a total of 49 participants, around 71 years old of age. Importantly, all these participants are cognitively unimpaired. They have no problems with their cognitive abilities. In those participants, on 45 of them, we had AD biomarker data from PET. And in this table, I show a breakdown of our numbers. We had 27 people that were AD biomarker negative, 9 that were amyloid positive, and 9 that were both amyloid and tau positive. And the people that had AD biomarker positivity, they're considered to be in this preclinical window of Alzheimer's disease. In this plot shown here to the right is one of these YAG curves that shows that Alzheimer's disease pathology accumulations begins 10 to 20 years even before any clinical symptoms manifest. So we're studying the preclinical phase of Alzheimer's disease. And here we have some of our findings. In this plot, I'm showing you the CSF flow velocities in the cerebral aqueduct as a function of these three groups. And what we saw was that CSF flow velocities were associated with AD pathology, with the fastest or highest velocities in those that had more AD pathology, in this case amyloid and tau. And from our blood flow imaging, we also saw in these groups that had more AD pathology, higher arterial blood flow pulsations. But we still don't know anything about CSF flow in the perivascular spaces where brain clearance presumably occurs. And in these other data, I'm showing you some correlation analysis of CSF flow dynamics as a function of aging in the plots to the left. Is CSF velocities, also cerebral aqueduct, as a function of age. And on the right plots, I'm showing you CSF flow dynamics as a function of the total CSF volume segmented from the structural T1 images. And what we observed was that higher CSF flow velocities were correlated with increasing age and larger intracranial CSF volumes. Cerebral aqueduct CSF velocities were also correlated with arterial blood flow pulsatility, where we have greater CSF flow range and CSF max flow with greater internal carotid blood flow pulsatility. And since we have the perfusion and blood flow data, we look at the correlation between perfusion from ASL and blood flow from 40 flow, and we found a moderate correlation with both total cerebral blood flow and venous blood flow correlated to gray matter perfusion. And we also saw this trend that lower perfusion correlated with higher pulsatility index. So a few take-home points. We observed significant CSF flow changes in preclinical AD. In those that were amyloid and tau positive, we found faster cerebral aqueduct CSF flow and blood flow velocities and blood flow pulsations. And we had noticed these vascular changes later, but perhaps there could be other factors weighing into these CSF flow velocity changes, or perhaps not. We cannot disregard that what we're seeing in CSF flow might be manifestations of changes in the vascular system as a driving force. We cannot say anything about metabolic waste clearance because to do this we need to measure the CSF flow velocities closer to the parenchyma, which is far away from the cerebral aqueduct. We observed some aging associations with older people with larger intracranial CSF volume having faster cerebral aqueduct CSF flow velocities. Again, definitely there's some vascular changes or driving forces from vascular origin driving these CSF movements. There is more atrophy in the older participants, and perhaps in these more atrophy brains there's also less flow resistance. And we observed neurofluid coupling with these associations between blood flow pulsatility and CSF flow dynamics. Perfusion and blood flow correlated. We are happy to observe that. I don't know if you know, but the correlations between ASL perfusion and 40 flow or phase contrast studies is not that great. There have been large studies conducted, and you get R-squared as 0.35. These studies use a single post-labeling delay, which might account for some of the lack of variability, but there might be other factors affecting this low correlation between bulk blood flow and perfusion measurements. And for our future studies, we want to collect, we need more AD biomarker data, and we want to extract full value of the coverage that we're having. Currently, we are just showing very limited data from the cerebral aqueduct. And eventually, we would like to have support for this subarachnoid space and perivascular spaces to study clearance. And with that, I would like to thank the participants, the lab members at EW, and our funding sources, and you for your attention. Thank you.
Thank you for your excellent talk. And open for question. So, yes.
Hi, Leo. Very nice presentation. Thank you. I was wondering if you could comment on noise in your data. It looked quite, the results look quite spreaded. And I was wondering on signal to noise ratio, given that the T1 time is quite long for CSF, was that an issue?
So you're talking more specifically towards the CSF flow sequence?
Yeah.
Yes, it was prospectively gated. It took a lot longer to acquire, and there was a lot more variability in the measurements. Also, I think the segmentation of CSF flow measurement is a bit harder because you don't have nice angiographic data to create masks. So I agree that they are a bit more noisy, and we have to improve our methods of extracting the CSF flow values, generating better segmentation masks.
Yes, because I mean, it could be that you actually could get significant results if the signal-to-noise ratio was better. This is just a thought on that, but thank you. Very interesting.
Thank you.
Quick answer, please.
Very nice presentation. Quick question, I'm a bit confused. So you found higher velocities, right? But higher velocities can be surrogate for better transport. So that's kind of opposite to your underlying hypothesis that in AD, transport is compromised.
So the location where we're measuring is very important. At the level of the cerebral aqueduct, which connects the fourth and the third ventricles and big lateral ventricles, what is happening there, hemodynamically speaking, could be very different to what is happening on the perivascular spaces adjacent to the blood vessels and the subarachnoid spaces. This is why I didn't want it to say, well, your point is well taken. It could help with transport, but I don't think at the moment, considering how far we are from the brain parenchyma, I can say anything more about it.
Yes, that's the problem. But it's increasing during sleep, right? So we're supposed to have higher velocities during sleep. So it seems to be beneficial, and yet we don't know how it links to lymphatic.
Right.
Thank you.
Thank you.
I have a quick question. Have you measured the area of the aqueduct?
We do have an area measurements. I don't have the data in these slides right now.
Is
but
the flow is correlated with the smaller the aqueduct?
I'll have to get back to you with that answer. Yeah.
Thank you.
Okay, so we'll move on to the next talk. From Ziming Xu from Tsinghua University, and her topic is blood-brain barrier breakdown and water exchange rate across the blood-brain barrier based on DCMRI in patients with Alzheimer's disease. Please.
Well, thanks for the introduction, and good afternoon, everyone. Welcome to my presentation. My name is Ziming Xu from Tsinghua University. Today, I'm going to talk about blood-brain barrier breakdown in Alzheimer's disease based on the water exchange DCE MRI. Alzheimer's disease, or AD, is the most common form of dementia and is believed to affect 5 to 7% individuals around about 60 years and older in China. And at the same time, AD has a rather complex pathological mechanism, including amyloid beta or A-beta clearance. And the blood-brain barrier, or BBB, is a key structure involved in A-beta clearance. Various postmortem CSF and brain imaging studies have highlighted the BBB damage in Alzheimer's disease. But these studies are almost invasive or qualitative, and they fail to assess regional BBB damage. In recent years, DCE and ASL are two emerging new MRI methods to assess regional BBB damage. And many DCE parameters, such as K-trans, could reflect the transfer rate of contrast agent across BBB. And many studies have shown that BBB leakage reflected by high K-trans in AD is associated with the degree of the AD. And the ASL technique employs multiple diffusion weightings to differentiate water from blood and brain tissue, and then calculate the water exchange rate, or KW. But the relationship between the water exchange rate and the degree of BBB damage remains unclear now. It's important to notice that the water exchange rate and the contrast agent exchange rate measure complementary properties of the BBB. And so in this study, we aim to measure the BBB leakage to contrast agent and water simultaneously to assess the BBB damage more comprehensively. And the shutter speed model for DCE can its potential to provide rich information for the above purpose. It includes 3 compartments: the blood or intravascular space, the intracellular space, and the extracellular space. This model could quantify 3 transfer constants, including KPE for contrast agent for contrast agent molecule from blood to extravascular space, and for KBO for water molecule from intra to extravascular space, and KIO for water molecule from intra to extracellular space. And this model involves simultaneously fitting process of Bloch-McConnell equation and Katie-Schmidt-Taprite law. But this model was developed for tumor tissue, which has a quite high exchange rate for both contrast agent and water. But we hypothesize that AD-related BBB damage is very subtle. So in this study, we replace the Katie-Schmidt-Taprite law with PADLAC model. The PADLAC model was believed to be the most appropriate model for in low leakage regimen. And this model could greatly simplify the fitting process. In this study, we included 25 AD patients and 24 age-matched healthy controls from the friends or relatives of the AD patients. And all participants were scanned with a 3D Prisma scanner with a 64-channel head coil. MP-RAGE, T1 mapping, B1 mapping, and DCE were scanned. And we also collected essential clinical and AD demographic information for all the participants. 3 tissue ROIs, including caudate nucleus, thalamus, and hippocampus, were chosen, and we extracted vascular input function from the superior sagittal sinus, like other previous AD-related studies. Representative CP and CT curves were shown in the right figure. Next is the result part. No significant difference was found in clinical information except MMSE, which is an assessment tool for AD. And this slide shows the representative KIO, KBO, and K-trans map in caudate nucleus of 1 AD patient and 1 healthy control. And the lower section of this slide highlights that there is no significant difference between the 2 groups. Next is the result of thalamus. We can find that AD group demonstrated significantly lower KIO values than HC group. And this slide shows the result of hippocampus. We can find that AD group showed significantly lower KIO and higher K-trans than HC group in hippocampus. This may be result from that the severe AD-related BBB damage was in the hippocampus. And then the BBB allows more contrast agent to pass through and results in higher K-trans. But at the same time, AD patients have fewer AQP4 channels and result in less KIO values and slower rate of A-beta clearance. We also investigated the relationship between the 3 aforementioned DCE parameters and plasma A-beta ratio, as well as MMSE. And we found that higher KIO in thalamus was significantly associated with higher MMSE, and higher K-trans in hippocampus was significantly associated with higher A-beta ratio and lower MMSE score. In closing, to our best known, this study firstly reported the BBB leakage to contrast agent and water simultaneously in AD patients, and the BBB permeability to water and contrast agent detected by this model showed a significant correlation with connective dysfunction. In the future, larger population and radiological pathological correlation studies are further needed. Finally, I would like to thank all the CBR members and our collaborators. That's all. Thank you.
Thank you for your presentation. Any questions? No question. I have a question. And you have 2 parameters for the water exchange, and the K-trans for the gadolinium exchange, right? But you only found 1 parameter KIO as there is significant difference between the AD patients and the healthy controls? And is it related to the mechanism of the AD, or is it indicator that this parameter is much more sensitive than the other parameters?
Yes, thank you for your question. And in our study, we found that KIO, there is a significant difference in KIO between the AD group and healthy control group. This is correlated with the previous study that AD patients have lower AQP4 water channels on the cellular membrane. But the KBO, there was no significant difference in KBO between the two groups. This may be related to the AQP4 water channels on the vessel wall. Maybe AD patient, and there is no significant difference between the two groups in the AQP4 channels on the vessel wall. And our study shows that KIO is more sensitive biomarker than KBO. This is correlated with the previous tumor studies. Yeah.
Okay, thank you. Thank you for your presentation. And so we'll move on to the next speaker.
Thank you.
And the next speaker is Dr. Saeed. We've heard the topic of her about carotid web in the morning, and we have another topic of her topic in the afternoon is the larger regions of low WSS and high OSA are present in patients with carotid webs compared to the patients with atherosclerosis and normal bifurcation. And please.
Thank you for your introduction. Yes, I did talk a little bit about carotid webs in the morning and from the vessel wall imaging perspective, and now I'm just going to talk a little bit about the 4D flow that we have done so far with these patients. So I have no disclosures. So I did discuss carotid webs in the morning, but a little bit of just a quick background. It is non-athral lesions. It's interluminal projections. It happens in that, like right at the ICA, right after the bifurcation. And it appears as a shelf-like or pyramid-like projection in the lumen. And it's mostly fibrous tissue. It has been associated with recurrent ischemic strokes, and it's mostly cryptogenic strokes. So it has been linked to up to 1/3 of cryptogenic strokes in younger patients compared to the atherosclerosis patients. So atherosclerosis roughly, and this is my population numbers, around 70 years old, while carotid webs are mid-40s. So they're roughly younger population that you wouldn't expect to see narrowing in their lumen. And so if we want to understand why these patients are actually getting clots in their carotids or in this specific region, we do need to understand a little bit about their flow. And so two parameters I chose for this presentation are wall shear stress and oscillatory shear index, because both of them have been linked to vascular dysfunction, endothelial vascular dysfunction, and thrombus formation. So the hypothesis of my talk here is that subjects with carotid web have more complex flow patterns that usually are represented by lower time average wall shear stress and higher OSI. And here I'm going to be characterizing by the area. And compared to mild atherosclerosis or normal subjects. So my methods, we have recruited 10 subjects with carotid web, mostly female, with mild luminal narrowing, and all of our subjects are symptomatic, so they have had a stroke or a TIA. And we had recruited 8 subjects with mild atherosclerosis. And actually recruiting mild atherosclerosis is really hard because you need just the right percentage, and most of atherosclerosis is not symptomatic at like 30 or 50%. stenosis. And then healthy volunteers. And we have scanned these subjects at our 3 Tesla system at Emory University, and we acquired our 4D flow MRI images using the following parameters. We did have a head coil and a carotid coil. So 4D flow MRI images are 4 sets of images. They're acquired in 3D volume and 3 different velocity directions. Foot head, left, right, and anterior, posterior, and through time. So we have around 24 time frames in the specific sets of images, and we combined these images to generate our MRA images. Then we did the segmentation, and this is my MRA segmentation, but since I did have information with this specific images, with the carotid web images, I did have a lot of information about the vessel wall. So I had a nicer segmentation for these images, especially here you can see there's a little bit of signal loss where the velocity is low. And we generated their streamlines using Insight and the time average wall shear stress or wall shear stress maps. And then we wanted an area of region of interest because we didn't want the whole domain. So we determined what is the maximum stenosis is, and we went 1.5 diameter downstream. And we did another segmentation for that specific ROI, and we looked at that specific section for our quantitative results. And here I'm showing just a little bit of qualitative results. So the top row is the normal subjects. And we can see, like, even in a normal subject with the 4D flow, we do have some complex blood flow. This is an athro case and a carotid web case at the bottom. And so here I have the wall shear stress maps for all of them. And we can see in patients with carotid web, there is a lower time average wall shear stress right at that bulbar segment or where that region of interest is. And then this is my OSI maps. We can see very similar pattern too. The normal actually didn't show as much high OSI, but not on all the subjects. So I do have some subjects where we did see like normally higher OSI compared to athro. And so I did segment all these sections from all the population to also standardize the method. And then I came up with this threshold where I combined all my results from my segmentation, from my ROI, and I chose the lowest 10% as a threshold, and that was my threshold for the low time average wall shear stress, and the highest 10% for the OSI. And that's how I quantify. That's how I found my region of the complex blood flow. And so here I'm showing a little bit of results. Here I'm showing the time average wall shear stress, the area of flow time average wall shear stress, and we can see that patients with carotid web actually had larger regions of flow time average wall shear stress compared to athro, where with athro we see that there is high velocity due to the narrowing, so we don't expect as much as of low wall shear stress compared to a high wall shear stress and the normal. And we also see these comparisons are all statistically significant. When we look at OSI, we see that carotid web and atherosclerosis are statistically significant, but when we compared it to normal, there was some normals where they had like this really large bulbar segment, but that also shows that time average wall shear stress may be better parameter compared to OSI. So finally, we showed that the time average wall shear stress in patients with carotid web patients with carotid web in general are exposed to lower time average wall shear stress compared to athro and healthy volunteers. OSI was also higher in patients with carotid web compared to athro, and this might also help us understand why these patients develop clots in these specific regions, even though when we're comparing them to subjects with similar luminal narrowing in athro. And hopefully we can answer why there's a clot formation with further studies in the future. Thank you all for listening. I would like to acknowledge my lab and all our funding resources.
Thank you. It's a very nice presentation. Any question from our audience?
Very nice follow-up from your earlier presentation. One parameter that I wonder whether you've thought of looking at is particle residence time, which would be a metric of the likelihood that you're going to form thrombus.
So actually, I do work with 4D flow a lot, but when we started looking at the particle residence time, we had some difficulties due to the limitation in the spatial resolution and in the temporal resolution as well. So we decided to run a lot of CFDs, and I have a lot of results coming up from CFD section about particle residence time, and preliminary results, it does show that patients with Gerard Webb do have higher particles just getting stuck there and like trapped for a while, up to 5 cardiac cycles at the right at this moment. And I'm looking at stasis as well, just like how long the blood is lasting, or how long the voxel is under a specific threshold of velocity.
That's great. Clearly, one of the big advantages of 4D flow MR is that even if you don't have the spatial resolution, the information about motion is contained in the vessel, whereas a CFD, you may not have the adequate spatial resolution to actually build your CFD model to accurately capture that, but 4D flow inherently captures it.
I totally agree.
Thank you for your talk.
Thank you.
Thank you, very nice presentation. And I was actually curious that you mentioned the thrombus formation, but then you decided to quantify the Worlscher stress and then trying to like link that to thrombus formation. But you also briefly mentioned in the answer to this previous question that you were also quantifying the blood stasis. And so I was actually interested in like where the blood stasis, the region of stasis actually corresponds to the region of low average Worlscher stress. And
it's really interesting because that specific where the bulbar is expanding, that's where we see most of the very low velocities. And that's where I'm looking at my next segmentation. So I think I'm gonna stick to that specific ROI. In general, that's where we expect most of the stasis is gonna happen. Is that your question?
And just one more question. So what was the like initial rationale behind quantifying Worlscher stress for the like clot, and then to investigate like a clot formation? So
Worlscher stress previously have been linked to a lot of vascular dysfunction and vascular remodeling. So it also like, not Worlscher stress per se, but shear rate in a lot of those biochemistry scary papers actually have been looked at that in comparison to, or like in correlation to clot formation. So that's where we started with that, and then now we're kind of branching out with other parameters.
Okay, thank you so much.
Thank you for a very nice presentation. And I have 2 quick questions. First is about how about another parameter called vorticity of the flow during maybe in the carotid bulb. The second quick question is that how about a patient both with the carotid web and the atherosclerosis plaque?
So I did look at vorticity extensively, and it was a little bit harder to make sense of the results because you needed a specific cross-section. And there is one cross-section that actually stood up the most to me, like right, I think I want to say like around 2 millimeter downstream, where you see this huge area with like very low vorticity separating the mainstream. Well, you don't see that with, you don't see that in athero. And normal actually was really interesting to see as well, because we see these smaller vorticities that are flushed out.
Yeah.
I'm happy to show you. I do have some cool videos on my computer.
Okay, thank you.
Thank you.
Okay, thank you again for your nice work. And our next speaker is Jin Zhang from Renji Hospital, China. And the topic is non-selective along with vessel-selective 4D MRA using pseudo-continuous ASL for assessing ICAL and the cerebral artery compensatory pattern. Please.
Dear professors and colleagues, thank you for having opportunity to make a presentation. My name is Zhang Jing from Renji Hospital, Department of Radiology. My topic is evaluation of cranial cervical artery occlusion by vessel-selective 4D MRA using super-selective Picasso, comparison with TOF MRA, CE MRA, and DSA. Collateral circulation is an important mechanism to maintain normal brain function during cerebral artery stenosis or occlusion. DSA remembers the clinical golden standard, while it has invasiveness and association of ionizing radiation exposure. The TOF MRA and the CE MRA can provide some information, while it is difficult for blood flow information. Recently, 4D MRA technologies are well established to visualize the cerebral arteries. Based on super-selective Picasso, 4D SPEC, completely non-invasive 4D method can provide hemodynamic information as comparable as DSA. This is a case of right ICA occlusion. The above pictures are from 4D PEC, and the below pictures are from 4D SPEC. By labeling the left ICA, we can see the primary collateral circulation via ACOA. In this condition, we want to know whether the 4D PEC and the 4D SPEC technologies can accurately and steadily evaluate cranial carotid artery occlusion and collateral circulation. We prospectively include the patients with cranial carotid artery occlusion diagnosed by US or CTA. The SCAN protocol includes TOF MRA, 4D PEC, 4D SPEC, and the CE MRA. We also gathered DSA as a reference. By labeling the cervical arteries, we gathered the 4D PEC images of the whole cerebral arteries. We also gathered the 4D SPEC pictures by labeling the CCA, by labeling each CCA near bifurcation and one of the VA, respectively. In the 14 patients of 16 cranial carotid artery occlusion, we can find 4D PEC technology accurately diagnosed all of them, shows it is not inferior to traditional blood imaging technology. One identification of collateral circulation, we can find 4D PEC and 4D SPEC. Mainly 4D SPEC can evaluate the source of collateral circulation better than TOF-MRA and CMRA. This is a typical case. From the left pictures, we can find right ICA occlusion. From the left pictures, by labeling the left ICA, we can find the blood supply of right MCA and ACA is via ACOA, as the same as the DSA shows. There is another typical case of right ICA occlusion. It is difficult for us to assess its collateral circulation by TOF-MRA and CMRA, maybe via ACOA, PCOA, or both of them, via from 4D SPEC. By labeling the left ICA, we can find no blood supply via ACOA. Via labeling the BA or VA, we can find the blood supply via PCOA, as the same as the DSA shows. 4D SPEC made better performance than TOF-MRA and CMRA in this condition. What's more, we found more information in 4D PEC pictures. We can find different ranks of delay of MCA angiography than the collateral one. Maybe this information is associated with TTP information. Let me make a summary. 4D PEC technology can accurately diagnose cranial carotid artery occlusion, which is not inferior to traditional bright blood imaging technologies. Combined 4D PEC and 4D SPEC, mainly 4D SPEC, can evaluate the source of collateral circulation better than TOF-MRA and CMRA. 4D PEC has the potential to diagnose the degree of collateral compensation. That's all. Thank you for your listening.
Thank you for your talk. And any questions from the audience? I think we are already behind the schedule, and thank you for the talk again, and we can save the questions later. So let's move on to the next speaker, Jinsen Chen. And his topic is patient-specific 1D modeling of the posterior circulation in moyamoya disease with a cerebral vasculature segmented from dynamic MRA. Please.
Okay, thank you for the introduction. So I'm Jinsen Chen from Fudan University. So today I'm going to talk about our study on our preliminary study about the 1D flow modeling for moyamoya disease patients. I have nothing to declare. So the 1D model is a simplified version of the 3D Navier-Stokes equation. And because of its low computational cost, it has been used to study the hemodynamics of arterial system. And actually, this method, the accuracies of this method resides on a good depiction and segmentation of the vascular network. And as will be shown by the other study, as will be shown by the other study, which will be presented by Leo on Thursday, the arterial spin leveling dynamic MRI actually has potential to better depict the cerebral arterial network length-off, especially for the distal branches. And the right figures shows an example images of the AS dynamic MRI from a moyamoya disease patient. Yeah, and this study focuses on the moyamoya disease patient. And we know for this disease, the subject will have progressive stenosis and an occlusion of the ICA and the MCA. So the posterior circulation will play a key role in the blood supply in the advanced stage of this disease. So this study aimed to explore the potential of the 1D modeling to quantify the hemodynamics of collateral vessels in the posterior circulation based on by utilizing the cerebral vasculature segmented from the ASL dynamic MRI. And we included 4 preoperative MMD patients, and the MRI images were acquired with 3 Tesla Philips scanner. And we used the iSNAP sequence, which essentially is an ASL MRI sequence to acquire the ASL dynamic MRI images. We also acquire the 3D phase contrast to get the velocity information. The right figure shows the pipeline for our data analysis. So we used an isolation forest algorithm, which will also be presented on Thursday, to segment the cerebral vasculature from the ASL dynamic MRI images. And then we use the Blender software to manually extract the posterior circulation and correct the segmentation. And from the 3D phase contrast images, we get the velocity map. And finally, we perform 1D flow modeling based on the vascular network extracted from the ASL dynamic MRI. And there's nothing new for the 1D modeling algorithm. We simply use the existing code developed by our co-authors. And in terms of the boundary conditions, we use the flow of the base artery measured from the 3D phase contrast as the inlet. And we also set the pressure for the outlet. And overall, this problem can be simplified as a problem of solving the linear system for the pressure. And because we know the length and radius for each arterial segment, so we basically can calculate the resistance for each segment. And after calculating the pressure, we can further calculate the flow for each segment. Here are the results for the first 2 subjects. So the first column is the velocity map from the phase contrast, and the second and third column are the flow rate map and pressure map from the 1D modeling. And the right figure shows the dynamic MRI images for the second subject. The basic observation is that for the pressure map can show a better changes, a more distinct changes across the arterial network than the phase contrast velocity map and the simulated flow rate map. And this information seems to provide a better visualization of the potential flow direction, which may be useful for evaluating of the collateral circulation. The other observation is, if you look into the regions, these regions, there seems to a higher density for the collateral vessels. And if we go back to the pressure map, it seems that this region also has a higher pressure. And these are the results for the other 2 cases, and the observations are similar. For a rough validation of the 1D modeling, we extract the velocity for these 5 arterial segments, the base artery, the left and right P1 and P2, and the y-axis here is the simulated flow from the 1D modeling. And we observed a significant correlation between these 2 parameters. So in this study, we found that the 1D modeling can generate hemodynamic information from the cerebral vasculature, and this information may be useful for evaluation of the disease itself, and may be also useful for studying of the underlying pathophysiology. And there are limitations for this study, so we have several assumptions. For example, we assume a mean pressure for all subjects. When we also assume the base artery was the only inlet for the posterior circulation, but of course the blood may have other source. And the radius, the measurement of the radius may not be, for the distal branches may not be accurate because of the limitation of the spatial resolution. And we didn't consider the anterior circulation at the moment, and the sample size is small. So this study represents an initial effort to improving the 1D modeling and the ASO dynamic MRI to assess the blood flow in the distal vessels of the posterior circulation of the myomyopathy patients. And there are still a lot of work to do in the future. Thank you for your attention. That's all.
Okay, thank you for your nice presentation. And any questions from the audience? Okay, I have a very quick one. And there is some communications between the anterior and the posterior, very small new vessels, and to provide some blood supply. And do you consider that in your calculation, or some blood supply from the superior temporal arteries, the extracranial arteries? Did you consider that in your study?
That's a very good question. We didn't consider that, but I know, for myomyopathy patients, the extracranial may also provide blood for the brain. Yeah, but just for simplicity, just for the simplicity of the study, we currently only focus on the posterior circulation. Yeah.
Okay, thank you again. So let's move on to the next speaker.
Thank you.
Thanks. The next speaker is Vitaly Reis, and the topic is 4D flow MRI velocity error quantification in the cerebral vasculature. And please.
Good afternoon. Good to be here. So I will talk about error analysis of 4D flow MRI. My background is not as much in medical imaging, but in computational fluid dynamics and biofluid mechanics. But the goal of my lab is to establish 4D flow MRI as a reliable tool of blood flow assessment, put it on equal footing with CFD in terms of reliability, reproducibility of the data. And as Susanna mentioned this morning, reproducibility and reliability of 4D flow MRI is the key issue. So we are developing methods for error analysis and uncertainty quantification of 4D flow MRI, just as biofluid community is developing uncertainty quantification of CFD, we're developing uncertainty quantification of 4D flow MRI, and that will serve as a quality assurance for 4D flow measurements in each voxel. It will enable reproducibility of 4D flow MRI that is acquired with different imaging settings, different scanners. It will also improve reliability of velocity-derived metrics, such as wall shear stress, responsible for triggering vessel adaptation and remodeling, because we can propagate uncertainty through numerical schemes used to calculate these velocity-derived metrics. And also, importantly, it will enable a rigorous comparison of 4D flow MRI data sets that are acquired in longitudinal studies and across subjects. So when you see a difference in measurement velocity, in the measured velocity, you can quantitatively assess if that's the difference because of the physiological change or just within the error of measurement. So the efforts in our lab on error analysis of 4D flow MRI are spearheaded by my student Sean Rosenberger, and Sean recently got his PhD and joined one of the imaging startups in Silicon Valley. But he started from looking at the bias error of 4D flow MRI due to insufficient resolution of the flow structures. And then we proceeded with developing a method for automatic segmentation of 4D flow MRI data. So this method is based on statistical inference and principles of fluid mechanics, and we identifying voxels that have net flow effects that are significantly different from background velocity distribution in the tissue voxels. And this method, unlike deep learning, does not require any training and it is very robust to changes in scanner settings, imaging equipment, flow conditions, and vascular territories. We recently published in IEEE Transactions on Medical Imaging on this. And so that's an iterative algorithm that is using an F-test. Basically, how do we find that flow voxels have net flow effects that are significantly different from the distribution in the tissue. So it's standardized difference of means, SDM, velocity, which is the difference between time average velocity measured in each voxel and tissue velocity over the normalized by the standard error of measurement. And so now we are extending this concept of SDM velocity to quantify the error of 4D flow MRI measurement. So we estimate the uncertainty of 4D flow MRI in each voxel by using the covariance of the velocity error. And covariance matrix is composed from the local variance of the velocity error and global correlation of velocity error across components of the measured velocity vector. We assess the local variance of the velocity using spurious divergence, using the mass conservation principle. And the correlations are obtained using SDM velocity in the background tissue. Sean also came up with a metric to assess the quality of 4D flow MRI measurements that he named velocity distance. And so velocity distance is the statistical distance between your local velocity measurement, your local velocity vector, and the underlying distribution of error. So velocity distance is calculated in each voxel and for each cardiac phase. And it is equivalent to inverse of the relative uncertainty. So high velocity distance would mean that you have low uncertainty and good quality of MRI data. Low velocity distance would be equivalent to being within the error of measurement. So velocity distance is similar to VNR, but it's extending velocity to noise ratio because it's also accounting for other sources of error such as limited resolution, partial volume, and phase wrapping. So very briefly, we estimate the covariance matrix of the velocity error as a combination of local velocity uncertainty and correlation of velocity error across the components of the velocity vector. And since blood flow is incompressible, divergence of the measured velocity can be used as a surrogate for the error of velocity measurement. And then we propagate the local uncertainty of velocity through the numerical schemes used to estimate divergence operator, and that gives us the local variance of the velocity for each voxel. Then we use the SDM velocity for the background tissue, suppressing the flow effect and looking at the correlation of error across velocity components. We also compared it to PELC model of uncertainty, and we found that we can account for phase wrapping, limited resolution, and partial volume effects. So it's an extension of the PELC model. We tested this uncertainty model in vitro and in vivo. So in vitro testing was done on a model of cerebral aneurysms. We 3D printed 2 replicas of internal carotid artery aneurysm data actually obtained from Susanna Schnell at Northwestern and Michael Markow's group from Northwestern. So we printed 1-to-1 and scaled by a factor of 2-to-1 model. And this way we can keep the flow similar by matching the Reynolds number, scaling the velocity. Use the same voxel size and adjust the bank according to the maximum velocity. So we see the change of the quality of our 4D flow MRI only because of the resolution, relative resolution. And so this image showing velocity distance and measured velocities. So velocities are in blue, velocity distance in orange. And you can see that velocity distance is higher when we have higher velocity, so the jet entering the aneurysm. You see that there is a region, it's the outlet from the aneurysm with low velocity distance, so that's due to phase wrapping. The velocity distance near the wall is very low. It's similar to the background tissue, so that's a low quality of MRI as expected. And in general, you see that 2-to-1 model has much higher velocity distance. That's because obviously we are resolving the flow structures. And so I want to mention that we use dual Wenck sequence that is provided by Michael Markle's group, and we did this at Purdue. Now, we also applied the same model to in vivo measurements in cerebral vessels. So here you see a cross-section going through the internal carotid artery with a large aneurysm. That's again in vivo data from Northwestern, and we applied our algorithm. So you see the difference between velocity distance at systole on the left and diastole on the right. Again, higher velocity distance in the jet entering the aneurysm, low velocity distance in the center of the vortex that is formed by the jet, and that's because we are not resolving the flow structure there. Again, low velocity distance both at systole and diastole near the wall, because we are not resolving steep velocity gradients due to no slip condition, due to viscous friction. That's the subject of the presentation on Thursday by our team, how to reconstruct that. And also you can see that at systole, velocity distance is higher than at diastole. So the quality of data is improved. So as a summary, these methods provide an algorithm for assessing the quality of 4D flow MRI data and enabling comparison across 4D flow MRI data sets. I want to acknowledge NIH support and the work that is done by my wonderful students in cardiovascular flow modeling lab at Purdue. This would not be possible to do this without my collaborator and colleague Pavlos Vlachos, who is an expert in error analysis, and also a picture of my 3-year-old daughter building an MRI scanner from her wooden blocks. Thank you.
Thank you for the presentation. It's very interesting topic, which is actually gives some possibility for application of this technique in intracranial imaging. And we are already beyond the time limit, so we'll save the questions for the break, and we'll move on to the next topic.
Okay, so now we will move on to the PowerPitch presentation. And the first speaker is Dr. Chen-Yan Zhao. His title is Predictive Value of Intracranial Atherosclerosis Coexisted with Atherosclerotic Plaque in Different Cultural Segments for Subsequent Vascular Events.
Thank you. Dear professors and colleagues, I would like to present today a study on the predictor value of the intracranial atherosclerosis coexisting with pancreas in different carotid artery centers. For the subsequent vascular events use magnetic resonance images. This is a prospective study. The picture on the left is the patient including, at last we required 122 patients with recent symptoms of the stroke. All patients underwent MRI to evaluate to the intracranial arteries and extract carotid arteries. The patients were followed at last 1 year to record any new vascular events. Some parameters are shown in the lower right picture. The presence of the pancreas is each extracranial cortical center, and the intracranial artery was determined. In the left right, we can show the carotid artery were divided into the 5 segments, such as DICA, PICA, CB, and DCCA, PCCA. The intracranial artery we used to arterial circulations like the MCA and the ACA. In total, we required 122 patients. The hyperlipidemia is significant difference can be observed in clinical risk factors between the 2 patients groups. After adjustment for the base confounding factor, intracranial artery stenosis remained significant in co-excited regions analyzed, and the co-exciting intracranial stenosis and pancreas in CB segment of the cortical artery remained significantly. KM curves can show that the intracranial arterial stenosis and the pancreas in CB segment of the cortical artery was significant other than. So the right picture is the examination. The upper is the baseline with the co-exciting pancreas. In the summer, we can know co-exciting the intracranial arterial stenosis and the pancreas in the segment of the CB was identifiedly associated with the subsequently vascular events. It can make our node co-exciting. This may have the higher predictive value for the vascular events than other cortical artery stenosis. Thank you.
Thank you. So next speaker is Dr. Yu Yang, and talk is quantitative study of QSM on vascular susceptibility in acute ischemic stroke.
Good evening, dear scholars and experts. Today, I want to share with you the quantitative study of QSM on vascular susceptibility in acute ischemic stroke. My name is Yang Yu. I'm from Shanghai People's Hospital, affiliated to Tongji University. This year, our hospital has established emergency diagnosis and treatment system for AIS patients. As we all know, time is important for patients' treatment. However, it's a great challenge to confirm the onset time of some patients' treatment. For example, wake-up stroke. QSM is based on SWI, which can provide some quantitative information of the brain vessel. Our research attempted to use the QSM to further obtain its correlation with the time of onset. We retrospective 40 cases of AIS patient with MCS thrombosis from 2015 to 2019. And we used the software spin to acquire the quantitative information of the healthy side and the affected side. Meanwhile, we measured the healthy side and the affected side. Meanwhile, we measured the relationship between the imaging indicators and the time by polynomial fitting curves. As a result, we found that the volume of dilated vessels, the suspectibility volumes and suspectibility volumes per unit volume of dilated vessels were larger on the affected side compared to the healthy side. That's shown on the table. And surprisingly, there was another interesting discovery. With the time increasing, we can see a generally decrease and increase trend were observed for the affected side in the volume and the susceptibility volume of dilated vessels. And through this study, those imaging indicators from the QSM might be valuable parameters to assess AIS caused by thrombosis. That is my all my report, and thank you for listening, and thanks for the invitation of SMIA. Thank you.
Thank you. So next talk is given by Dr. Haruo Isoda. The title is Hemodynamics and Morphology Influencing Intracranial Neurosmal Growth with the use of MR fluid dynamics and computed fluid dynamics.
Thank you, Mr. Chairperson. Sorry, but Shunsuke is not here because his schedule, so I will make a presentation in his place. Hemodynamics and morphology plays an important role in the development, growth, and rupture of intracranial aneurysms. The purpose of the study was to clarify the characteristics of the hemodynamics and morphology involved in IA growth using magnetic resonance fluid dynamics MRFD analysis with the use of 4D flow MRI and 3D TOF MRI, and computation fluid dynamics CFD analysis based on patient-specific MR information. We consider that the aneurysm show an increase of 0.18 millimeter or more per year were growing. Others were considered stable. We have 18 growing IAs and 71 stable IAs. We used the WSS, SWG, OSI, and GON, and RT as biomarkers. And first we present the result that are not classified as bifurcation or sidewall aneurysm. The left slide was by MRFD, and the right was is CFD, and you can see the vertical axis is a biomarker, and the growing group, and the stable group, and the vertical axis. WSS and SWG were divided by the mean apparent arteries. And you can see the trend, it is almost the same, but WSS was low, and there is no statistical significant differences between the growing and the stable group. Next, we will show you the result reclassified by bifurcation or sidewall aneurysm. This slide shows the result of bifurcation IAs, and SWG by MRFD and WSS by CFD show statistical significant differences. This slide shows the result of a sidewall IA, and there are no statistical significant differences in any of the biomarkers. The following show the comparison when the boundary values are defined by size. IA with volume of 40 for the aneurysms with the volume of less than 40 millicubed, which correspond to IA with the diameter of 4.3 millimeter. There is a significant difference between the SWSD and by MRFD and WSS by CFD. We examine the correlation, the annual growth rate of growing group with the hemodynamic biomarkers. This is the first MR examination and the growing area and the stable group, stable area. And it can be read that there is a strong correlation between the annual growth rate of volume and surface area and the area WS is calculated by MRFD. So in conclusion, we suggest that WSS and SFG are useful as indicators to predict the growth of bifurcation aneurysms and small aneurysms. We believe that the growth rate of the IA can be predicted by identifying the site of enlargement and tracking and measuring the WSS and SFG over time. Thank you very much for your kind attention.
Thank you.
So let's welcome our next speaker, who is Tian Bing, and the topic is preoperative clinical and imaging characteristics associated with aneurysm recurrence after stent-assisted coil embolization. Please.
Okay, thank you for the introduction. Good afternoon, ladies and gentlemen. It's my great honor to be here to share our work about the preoperative clinical and imaging characteristics associated with aneurysm recurrent after stent-assisted coil embolization. We know the stent-assisted coil embolization is the main endovascular treatment of intracranial aneurysm. And previous studies show that many factors are associated with recurrence after coil embolization for the intracranial aneurysm, including the clinical and the imaging factors. And this study aimed to explore the baseline clinical and imaging characteristics that can predict aneurysm recurrence after stent-assisted coil embolization. And this is a retrospective study. 155 patients were included in this study. And all patients underwent preoperative 3D high-resolution MR visual imaging. Regular imaging follow-up was conducted to monitor for recurrence after embolization. And the preoperative clinical and imaging factors were recorded, including the sex, age, symptom, hypertension, smoking, and imaging factors, location, maximum size, neck width, aspect ratio, and aneurysm wall enhancement. For the aneurysm vessel enhancement, we divided the enhancement pattern into 3 patterns. Classified as circumferential AWE and focal AWE and negative AWE. And univariable and multivariable logistic analysis were used to test the clinical and imaging factors associated with recurrence. And among the 155 patients, about 16.7% got aneurysm recurrence after stent-assisted coil embolization during the 2-year follow-up. And we got 40% CAW and 31% FAWE and 29% no AWE. And this is some image. And the multi-variety logistic regression analysis revealed that the CAWE pattern and aspect ratio were independently associated with aneurysm recurrence after stent-assisted coil embolization. And this is a patient, a male patient, 46 years old, and we can see the CAWE can be found preoperative high-resolution vessel wall image. And the patient got stent-assisted coil embolization, and the recurrence can be found 1 year after the embolization. In conclusion, the baseline 3D HRMR provides no insight into the stability of aneurysm after endovascular embolization, and the aneurysm with CAWE pattern and higher aspect ratio may be less stable after stent-assisted coil embolization. And thank you for attention, and thank you for my college. Thank you.
Thank you very much for the presentation. And our last speaker is Dr. Thorsten Bley again. And the topic is MRI depicts intracranial manifestation of giant cell arteritis. Please.
Thank you very much. Well, you know my disclosures, but here's a disclaimer. I'm not a neuroradiologist. I'm a vascular radiologist who took the liberty to cross the border and go to the intracranial vasculature as well. For this prospective bicentric case control study with 105 patients, 55 of which were proven GCA patients, and 50 were cancer patients who received brain MRI with contrast enhancement for their staging purpose, and we had an add-on with a high-resolution sequence, an isotropic 0.55 millimeter post-contrast compressed sensing 5-fold accelerated space sequence with a 64-channel head coil on the PrismaFit. And 2 neuroradiologists evaluated the circumferential homogeneous thickening that we know as the donut sign in the vasculitis, or if it's along the vessel tract, the tram track sign that we have discussed earlier. Before we look in vasculitis, let's have a short look at the control group. Those are patients without any signs of vasculitis, neither clinically nor in laboratory chemistry. And what we do see is homogeneous vasovasorum or some focal spots of atherosclerotic enhancement that is less than 360 degrees. And finally, what we have seen in many cases earlier today, this plaque formation, which is eccentric, and that also is one of the answers to Giles' question earlier. So it's morphology to determine vasculitis, which is circumferential, homogeneously enhancing. And these are the cases with positive findings, and you can see the donut sign if it's a cross-sectional view, or the longitudinal view, the tram track sign of patients with intra-individual comparison. For the right ICA, there is signs of vasculitis as compared to the left ICA without any signs, and different territories displayed here. And unexpectedly, there was a high manifestation of intracranial vessel wall enhancement that we consider vasculitis in 16.3% of our patients, typically in the ICA in 7 patients, in the vertebral artery in 4 patients, basilar artery in 1 patient, and posterior cerebral artery in 1 other patient. So the key point is unexpected high frequency of intracranial manifestation of this systemic disease that used to be, if you look into literature, only extracranial involvement. And it is most frequently in the ICA, and interestingly, those patients did not have any focal neurological deficit. However, they did have headaches. Thank you very much for your attention.
Thank you very much for the presentation. Thank you.